Hello there, my name's Nivian Sukirthan. I'm a recently graduated final year Barts med student. Today I'll be attempting to cover pre and post-operative care. It comes under your Met3A module, but it's also revisited as part of the spiral curriculum in year 5 under the anaesthetics, critical care and surgery module. So today will just be sort of a taster really of pre and post-operative care, and hopefully you can take these principles forward into your upcoming surgical attachments, as well as in both third year and final year. The sources I've used predominantly today include the Met3A lecture week, the Oxford Handbook Clinical Medicine, and finally PassMed. So what we'll be covering today. So the principles of pre-operative care is where I'll start off with, and then trying to move on to classification of the different types of post-op complications, and then general post-op complications that you may see with all types of surgery, and then some specifics. I won't be able to cover all the post-op complications of every surgery out there, but I could signpost you to PassMed. It has a really good summary really of different sort of complications with relation to anatomical principles, which will be a very good thing to look at. I won't be covering that here just because it's already available to you, so I'll be covering a few other things to be aware of relevant to Met3A. Okay, so let's start off with pre-operative care. So this basically, we're thinking about optimizing a patient's health and well-being prior to surgery, because we know that if we improve things like their cardiorespiratory fitness, exercise tolerance, oxygenation, things like this, it improves the prognosis and the outcome of surgery. So that's why this is actually a very important bit of not just anesthetics, but also when you're involved in a surgical rotation during your F1 or F2 years and beyond. So, the overall aims of pre-operative care. So we're trying to provide diagnostic and prognostic information, making sure the patient understands basically what's going to happen to them. It can often be quite a frightening experience, so we need to make sure that the patient is well aware of what they're letting themselves into, and that's why consent is very much a major part of the pre-operative care process. Making sure that you've got the correct patient for the correct surgery. So what I mean by that is checking the demographic data, name, date of birth, NHS number, hospital number, making sure that it's the correct surgery. For instance, particularly if you're thinking about, amputations, for instance, you want to make sure that you're doing the right site, the correct site, marking it, all that things. Symptoms and signs, so things may have changed since the pre-admission clinic appointment, so being aware of that. Thinking about the risks of anesthesia, namely to do with breathing really, but may even be to do with reactions to the anesthetic agents. As I touched upon earlier, we want to maximize their cardiorespiratory fitness to improve the outcomes of surgeries. Thinking about comorbidities under the past medical history, whether they're taking irregular medication, whether that needs to be stopped pre-operatively. Are they a smoker, and would they be interested in quitting, which could help their surgical outcome, improving their oxygenation, and of course we need to liaise with the anesthetics team, which are heavily involved in this process. So, the pre-operative checks that need to be carried out. Things to consider: cardio-resp predominantly, measuring their exercise tolerance, have a look at the past medical history, any previous health conditions, so I'll just edit that. And then having a think about also their drug history, and also if they've had any previous surgeries and if they've had a bad reaction to anesthetic, antibiotics, anything like that. If we're also going to think about intubation, where we're basically putting a tube down the trachea to ventilate the patient, is their neck stable? There are certain conditions which predispose to atlantoaxial instability, including rheumatoid arthritis, ankylosing spondylitis, Down syndrome. They may also have neck stiffness due to osteoarthritis, so it can often present with problems associated with intubation. Do they have a past medical history of myocardial infarction, diabetes, asthma, high blood pressure, rheumatic fever, epilepsy, and jaundice? Could they potentially be pregnant, in which case certain things are contraindicated, for instance CT scans? Has there been use of anesthesia before? Exactly, so have they had previous surgeries and any associated complications from those? Thinking about special tests, so for sickle cell disease, particularly more prominent in certain populations, Afro-Caribbeans, Mediterranean, etc. And finally, thinking about if it's a particular site of the surgery, so, as I alluded to earlier, so if it's an amputation of the right leg, making sure that that's specified and, is adhered to. So, in the family history, things to consider. Really, you're thinking about sort of inherited problems that could pose a risk when patient undergoes anesthesia or surgery. So, one to be aware of really is malignant hypothermia or hyperpyrexia. It's an autosomal dominant inherited condition. It's quite rare, and it's often triggered by sort of volatile anesthetic agents such as succinylthonium or halothane, and it's sort of characterized by a rapid rise in temperature, so around 1 degree Celsius every half hour. The first sign can often be spasm of the masseter muscle in the face, the muscle of mastication. Patient may also have sort of metabolic abnormalities, so high potassium, low oxygen, high carbon dioxide, and could even have arrhythmias. Treatment is dantrolene. Moving on to sort of referring to the ITU team to take care. And then there are some other conditions to be aware of, but not so much. I'd stress perhaps the cholinesterase. So you're thinking about myasthenia gravis, Lambert-Eaton myasthenic syndrome, particularly when you're considering those depolarizing agents, i.e. used in anesthesia. And finally, sickle cell disease we've touched upon earlier. So some drug specifics, really. So some antibiotics can increase neuromuscular blockade. It's important to be aware of those. Tetracycline and neomycin are just some examples. Anticoagulants, again, they're obviously going to increase the risk of bleeding. So therefore you may need to avoid certain routes of entry to give anesthesia, so epidurals, spinals or regional blocks. The evidence is that aspirin, really you want to be continuing it unless there's a major risk of bleeding, because you've got to weigh up the benefits and the risks. Clopidogrel, often used in patients post-MI, post-stroke for secondary prevention. You want to really be liaising with the cardiac team or neurologists, depending on the situation of course, to see whether they'd be comfortable, withdrawing that medication for the perioperative period. Moving on to anticonvulsants. So these are given preoperatively as per usual. Post-op, depending on whether the patient, is still nil by mouth, they may need to be given through the intravenous route or through NG tube. Just a specific here, so sodium valproate, that you give the usual dose IV. Phenytoin, you have to give it slowly IV, and make sure to put a cardiac monitor on the patient. Beta blockers are continued because it precludes a labile cardiovascular response. And finally here, oral contraceptive pill. It is prothrombotic. There is a risk of DVT and PEs. Therefore, you stop 4 weeks pre-surgery and then you can restart 2 weeks after, provided the patient is moving, mobile, etc. A few more drug specifics. So digoxin or digoxin. So you should continue this up to and including the morning of surgery, making sure to check there's no instance of digitoxicity, which you can see on the ECG with the reverse tick sign. There are things that potentiate the toxicity of this drug, namely hypokalemia. So obviously think about using these as a blood test for that. Diuretics. Diuretics are especially loop diuretics, are sort of fabled and to sort of drop electrolytes across the board. So, hypokalemia, hyponatremia, magnesemia, all that stuff. So be aware of that, therefore do use an ease. Eye drops, so timolol is often used in things like glaucoma. It's a beta blocker, so be aware that it can be systemically absorbed in some cases. HRT, hormone replacement therapy, same sort of principle as the oral contraceptive pill. L-DOPA, L-DOPA used in Parkinson's disease, very important. There is a risk of arrhythmia when the patient is under general anesthetic, but it is advised to continue it in Parkinson's patients because some of the sort of abnormalities they face without continuing L-DOPA can often be quite severe. Lithium there, often used in things like bipolar disorder, can potentiate neuromuscular blockade, so very important when we're thinking about giving these quite powerful anesthetic agents. Monoamine oxidase inhibitors, so again used in psych, predominantly in things like, they used to be used, not so much nowadays, but used to be used in things like depression, and we need to be wary of things like hypertensive crises as a result of tyramine surge and hypotensive crisis as well. And finally here on this slide, tricyclic antidepressants, again less use nowadays due to the sort of dirty drug nature, as it were, because it affects a whole array of receptors, not just the ones that we want to in mental health problems. So other receptors in the heart, sodium, particularly sodium channels, histamine, alpha receptors, serotonin, dopamine, they're all susceptible to TCA, so there's a wider range of problems associated with TCA use there. So, how we prepare a patient pre-operatively. So nil by mouth for at least 2 hours for clear fluids and 6 hours for solids. We may need to consider bowel prep, so enema, and skin prep, cleaning the skin, etc. Whether we may need to give prophylactic antibiotics. Deep vein thrombosis prophylaxis with TED stockings. Bear in mind you can't give that in peripheral vascular disease, so just think about that. Low molecular weight heparin, again, to prevent DVTs. Any meds that you want to consider stopping or continuing, any investigations you need to do. Catheterization to reduce the sort of bulk in the abdomen, which can often help when operating within that vicinity. And then just consider, again, cardiorespiratory problems. COPD, arrhythmias, high blood pressure, valvular problems. So here's quite an extensive checklist really of things to consider when someone presents for an operation, surgery. So blood test wise, you're thinking about clotting and sort of group and save cross match. Checking their full blood count, electrolytes, kidney function and liver function. Urinalysis, pregnancy test, sickle cell test, putting in a cannula because you'll probably likely need to give them fluids, ECG, chest x-ray, ECG again to check for those arrhythmias, chest x-ray for any sort of lung pathology, COPD sort. Drug chart, so some common drugs associated with surgery, so antiemetics, very, very commonly used post-surgery. Antibiotic use as prophylaxis, or indeed if someone develops an infection post-surgery. Analgesia of obviously varying types. Regular meds that the patient may be on for various chronic health problems, and of course the heparins, which I have touched upon earlier. Unfractionated heparin, just to note, is not very commonly used for sort of thromboprophylaxis. LMWH tends to be used, but in those with renal failure, unfractionated heparin is preferred. TED stockings, getting informed consent from the patient, making sure they have capacity to make the decision, making sure you know where exactly you want to be making that incision, so marking the site, liaise with both the anaesthetics team as well as theatres, assess infection risk for various microorganisms, viruses, etc. How long have they been nil by mouth? Make sure to remember those rules. 2 hours for clear fluids, 6 hours for solids. And then the surgical safety checklist, which will be done pre the patient coming. So will be done during the sort of in the anaesthetic room, making sure that it's the right patient, right surgery, whether the patient has consented, all the investigations that need to have been carried out and what they showed, and all those things. And you'll find the surgical safety checklist if you just search it up online. PassMed also has quite good explanation of it as well. Okay, so some specific conditions and what we need to consider in preoperative care. So as we know, diabetic patients have a great degree of risk of complications, and not least because often people with diabetes have other coexisting comorbidities as part of the metabolic syndrome. Poorly controlled diabetes, obviously they have a high sugar, high amount of sugar circulating, higher risk of wound infections, and poor sort of dealing with those wound infections. The immune system isn't quite there. In terms of sort of differentiating between the two main types of how we manage diabetes, so those who are controlled with diet or tablet can be managed using the emission of medicines and checking their blood glucose regularly. And those who are poorly controlled, though, or take insulin, you need to put them on a variable rate intravenous insulin infusion. And potassium supplementation, because insulin drives potassium into cells, so you might deplete their potassium levels if you give them too much insulin. And always, if you can, operate on diabetic cases first to prevent hypoglycemia as a result of fasting rules. In emergency, we need to we still need to do your preoperative checks and stuff, but you've also got to bear in mind that this is time critical. So try and stabilize, resuscitate the patient. A to E approach as always. More emphasis on C, fluid balance and things. Consider whether antibiotics are needed. For instance, if it's an open wound, if we're thinking about like an orthopedic presentation, so it's open wound, skin is revealing broken bones, etc. We need to give antibiotic prophylaxis, just for instance. Informing the sort of blood bank if you're anticipating major blood loss, such as ruptured abdominal aortic aneurysm. And of course, as always, if consent is of paramount importance. So, some special cases and what we need to consider. So, thyroid surgery, if you just think about the anatomy, the vocal cords are in very, very close proximity, as is nerves such as the recurrent laryngeal nerve. Parathyroid surgery, you use methylene blue dye to identify the particular gland that is sort of abnormal, is producing more of the hormone. Sentinel node biopsy, often used in breast patients. Surgery involving the thoracic duct, basically administering of cream. Pheochromocytoma, that's the tumour which within the adrenal medulla that's producing a lot of adrenaline, so we need to prevent that by initially alpha blockade followed by beta blockade. The reason why we do alpha before beta is because if we were to block the beta first, that would leave alpha unoccupied, and that can often cause vasoconstriction, when adrenaline acts upon those receptors, and that can cause a crisis, a hypertensive crisis. So that's why we do alpha first, followed by beta blockade. Carcinoid tumours, it's to do with serotonin, and it's a sort of, we can get a carcinoid crisis, often when you manipulate the carcinoid tumour, often found in the appendix. So we cover with a somatostatin analogue known as octreotide. Colorectal patients, bowel prep, with enemas and things that patients often do a couple of days before the surgery. And then thyrotoxicosis, thinking about iodine or medical therapy to sort of basically anti-thyroid drugs, so things like carbimazole, propylthiouracil, to reduce the amount of thyroxine production. So you do those tests, which I mentioned that checklist earlier, and you find some abnormalities. So what do you do then? So you do things like, as I said, full blood count, urea, electrolytes, blood glucose. If the patient is anemic, you need to tell the anaesthetist. Usanies are important, not least in patients with renal problems, but also because if you're starving someone, check it in obviously diabetics, those on diuretics for the reasons I mentioned earlier, with all the dropping of electrolytes in loop diuretics especially, Burns patients and those with hepatic renal disease, as well as ileus, which I'll come on to in a later slide, and those receiving parenteral nutrition. Cross-match, we're identifying the blood type, and units are sort of given to the appropriate patient. Group and save, you identify the blood type, you keep it, hold it for the cross-match to come, and you may act upon that as and when the time prevails. Some specific blood tests, so liver function tests in people who abuse alcohol, if we're thinking about malignancy, liver mets, etc., jaundice. Amylase, good one to consider in those with acute abdominal pain, query pancreatitis. Drug levels, clotting function in those with liver, renal disease. DIC may be as a result of, again, may be pancreatitis, may be sepsis, so it's important there. Massive hemorrhage, again, clotting is going to be affected, and if they're on certain drugs, so warfarin is just a classic, heparin and valproate. So think also about infection risk, HIV, hepatitis B, sickle test for certain ethnicities, as I've mentioned earlier, and thyroid function tests. And then moving on now away from those blood tests to more sort of non-bedside investigations. So chest x-ray, if you're worried about cardiorespiratory disease, COPD, the like, lung mets, etc. ECG, for if you're worried about things like arrhythmias, those with a poor exercise tolerance, or those with previous cardiac history. Echo, if there's valvular problems or you're suspicious of low LV ejection fraction. Pulmonary function, again relevant in things like COPD, asthma. Doing a C-spine x-ray, again I've touched on this earlier, but it's to do with those patients with atlantoaxial instability and risk of difficult intubation, so rheumatoid arthritis, ankylosing spondylitis and Down syndrome. That are those that just come to mind. And finally, MRSA. So I touched on infections earlier. MRSA is a key point here because it is a very, very serious bug patients may be afflicted with. So we're trying to minimize that transmission. So if we can put that patient at the very end of the operating list, thoroughly cleanse, as per usual, but thoroughly cleanse the operating table, theatre, etc. And if we keep them at the end, there's obviously lower risk of transmitting to all the other patients throughout the entire day if they were to have been put first on the list. Antibiotics that seem to work against MRSA include vancomycin and teicoplanin. Right, so the final couple of things I want to mention under pre-op care is the ASA grades, the American Society of Anesthesiologists, and they've come up with a set of grades, basically, 1 to 6, of defining sort of your different type of patients presenting to surgery and the various risks that each one is sort of attributed to. So 1 is your normal healthy patient, 2, a patient with a mild systemic disease, 3 is someone with a severe systemic disease but isn't incapacitating and doesn't cause a constant threat to life. 4 is basically the reverse of that. It's a severe systemic disease that does cause a constant threat to life. 5 is a moribund patient who isn't expected to survive even within 24 hours, even if they were to have the operation. And 6 is essentially brain dead with organs being removed for organ donation. So I think what would be quite helpful is basically to go through some of the, how would you define mild systemic disease or severe systemic disease? So it's quite good to know a couple of examples under, some of the grades. So 1, healthy, non-smoking, no or minimal alcohol. 2, if they're maybe perhaps a current smoker, social drinker, maybe pregnant, things like this. 3, so they may have functional limitations, they may have poorly controlled diabetes or high blood pressure, COPD, morbid obesity, hepatitis, alcohol dependence, that kind of stuff. 4, if they've got a recent history of myocardial infarction, cerebrovascular accidents, things like this. And finally, number 5, so these, as I said, the ones that are unlikely to survive 24 hours even with the operation. So ruptured AAA, massive trauma, bowel ischemia, things like this. Okay? Right, so that's pretty much it really for pre-op. So we've covered, sort of the things that we need to consider in the history with pre-operative care, the blood test that you need to do, the investigation that you need to do, and we've thought about the ASA grades. So now I'll move on, as I said, to post-op complications. So post-op complications, there's loads of ways of classifying it. Some people classify it according to the cause, so is it due to anesthesia, is it due to surgery? Some may classify it according to time scale. So if you see this table here, you can split it up into immediate, early and late. So immediate post-op complications may include shock, hemorrhagic cardiogenic, arrhythmias, traumatic visceral injury and systemic inflammatory response syndrome. Early complications, so those between 1 to 7 days, include pulmonary atelectasis, where the lung basically collapses, often due to poor ventilation from the patient. Paralytic ileus, I'll come on to that in a bit. Renal failure, often due to poor fluid intake. Anastomotic leak, infection complications, pneumonia, UTI, surgical site complications. And finally, late ones would be sort of VTE, so that's venous thromboembolism, so DVT, PE, that kind of stuff. Intra-abdominal collections as well. Key thing to note also is post-op hemorrhage actually can occur anywhere in this time scale. So this is quite a good way of classifying it, but I will come on to some others. Okay. So we can split up post-op complications really into general and specific. So general really associated with all types of surgeries, not really very surgery specific, and then obviously the specific ones which I'll cover towards the end of the lecture. So a key one to know is pyrexia. Pyrexia is quite difficult really as a surgical F1 because it's often the common sort of theme as to what an F1 in surgical rotation at least has to identify and think about the root or the cause of that pyrexia. And it can often be helpful to think about this table that I mentioned earlier. So thinking about how many days post-op they are, what is the most likely cause. So mild pyrexia in the first 48 hours can be due to atelectasis. Treatment really is just physio. Other causes of pyrexia, again, in the first 48 hours may be tissue damage, blood transfusion, specifically febrile non-hemolytic transfusion reaction. Look for infection. Think about the different sites. So is there peritonism? In which case, do you think it's an intra-abdominal collection? Is it a chest infection? So do they have pleuritic pain? Is it a UTI? So do they have pain on urination? Or is the urine malodorous? Is there a wound infection? Key thing there, have a look at the wound. Is there discharge coming out? Does it look healthy? Is there phlebitis? So have a look at the cannula sites. That's why we have a VIP score. So to have a look for phlebitis at the site of the cannula insertion. Meningism. So headache, neck stiffness, photophobia. Those are your classic ones. And endocarditis. And you'll probably need to do bloods for that and do some cultures. Right, check the legs for DVT. So a unilaterally swollen, hot, red leg post-surgery, roughly around a week after surgery, points towards really a DVT. And you need to be getting an ultrasound Doppler on that leg. Send off some bloods for blood count, use an ease, inflammatory markers, LFTs, and blood cultures. Dip the urine, simple bedside investigation, can reveal quite a lot really. You're looking for things like nitrites and leukocytes. Midstream urine sample, chest x-ray, abdominal ultrasound, CT. Again, you're trying to localize where this infection may be coming from, if you do think infection is the cause of the pyrexia. One thing I was taught actually under the Met3A module was the 7 C's. So these are sort of sites where you may think that the pyrexia is originating from. So catheter, cannula, central line, the calf, so that's really a DVT, cut, wound infection, chest, like a pneumonia or atelectasis, and collections, so like an intra-abdominal collection from an anastomotic leak, for instance, when you're trying to anastomose the bowel. So here you are really. So there's a brief summary of causes of post-op pyrexia with relation to timescale. Okay, fine. So moving on now from pyrexia to confusion. Confusion can often happen in the elderly, often as a result of things like delirium, but it can also happen in those who've just undergone surgery with anesthesia, general anesthesia really. So some, however, are affected more than others, so they may well be agitated, disorientated, trying to leave the hospital at night. So make sure to reassure the patient. Okay. The most common cause of confusion can often be hypoxia. So put a SATS probe on and assess that, and think about the causes of hypoxia. So it can be pneumonia, atelectasis, LV failure, or indeed a pulmonary embolism. Certain drugs, so opiates, things like morphine, fentanyl, codeine, benzodiazepines, so diazepam, lorazepam, temazepam, and sedatives, really the same sort of class. Urine retention, so if you've got a obstruction post bladder, so in the urethra, or the catheter itself may perhaps be blocked, that can lead to urinary retention and can present as confusion. MIs, strokes, infection, particularly important in those who may suffer from delirium as well. Alcohol withdrawal. Bear in mind that obviously the patient is not going to be drinking alcohol during their stay at hospital, so all the various things associated with that, they may well be withdrawing, especially if they're a very, very heavy drinker. So, keeping awareness of that is essential. And finally, liver renal failure as well. So treatment, they may well need sedation. Try obviously to calm the patient down non-pharmacologically. And if that doesn't happen, if the patient's aggressive, you may need to step up to medication. Often one that's used is lorazepam. Try use it orally, and obviously if the patient is refusing, you may need to give it intramuscular. Or haloperidol can be given. It is, however, contraindicated in dementia with Lewy bodies as well as Parkinson's disease, because it can induce Parkinsonism in these patients. So stick to lorazepam in that subset. However, one thing to be aware of though is post-op confusion is actually very common and in the most part reversible. Dyspnea and hypoxia now. So do they have any previous lung pathology, COPD, asthma? Sit the patient up, give them high flow oxygen and monitor their SATs really, and examine for causes of hypoxia. So it could be pneumonia, again atelectasis. Is it aspiration as a result of tubing the patient, or the risks with that, the anaesthesia, etc. LV failure, PE, pneumothorax. So consider those, and investigations for this apart from the SATs probe would be full blood count, ABG, a chest x-ray and an ECG. Post-op hypotension. So first thing to do, again, get the OBS, so heart rate, blood pressure, SATs probe, give them oxygen if required, make sure to tilt the bed head down, prevent the blood rushing to all those places that it need not to. Post-op hypotension, think about the cause. So could it be hypovolemia? Maybe you're not giving the patient enough IV fluids. Bear in mind they've been fasting for a long time. Pre-operatively as well as during the operation, so you may not be covering losses. So bear that in mind. Think about also, could it be due to hemorrhage, blood loss that could be leading to hypovolemia? So monitor their urine output. Catheterize them is a really good way of establishing whether a patient is in normo or hypovolemia, and you may need a central line. If you're suspecting a bleed, good place to check would be the wound itself, or having a palpation of the abdomen if that's where the surgery happened. If they're unstable hemodynamically, obviously do your normal A to E approach, liaise with theatres and get them back in. And then other causes that may not be related to fluids or blood loss may include MI, PE, could be sepsis or anaphylaxis, perhaps to the anaesthetic agents or the the antibiotics they've been given. Right. You may also get post-op hypertension, and this is often caused by pain. Urinary retention may well be idiopathic, especially if you've had to stop the patient taking their normal antihypertensives. Good example would be, for instance, ACE inhibitors, so lisinopril, ramipril, enalapril. These drugs are often stopped in patients with renal problems because they are nephrotoxic. Ideally, you'd continue antihypertensive though throughout the perioperative period, even if they're nil by mouth, and treat the cause. So you may well need to increase their normal regular antihypertensive medication, or you may need to use labetalol, which is both a alpha and beta blocker. Now, moving into oliguria. So oliguria really is low urine output. Urine output roughly should be in the range of above 0.5 mils per kilo per hour, or around more than 30 mils per hour in adults. If someone's got anuria, you need to be thinking, is it a blocked catheter? In which case you may need to flush it. If it's oliguria, so there is some urine coming but not to the quantity that you'd expect, do you think you're not replacing enough fluid for the losses? Bear in mind, losses can just be urine, stools, maybe it'll be insensible losses through sweat, especially if someone's febrile. And obviously think about when someone's abdomen has suddenly been opened during surgery, all that moisture within the abdomen has all been evaporated into the operating theatre. So there's a lot of fluid losses during surgery, so you've got to really consider that. So you may well need to increase their fluid input. AKI, acute kidney injury, could be the end consequence of low fluid input. So it may again be caused by hypovolemia, as well as shock, certain medications, specifically ACE inhibitors, or some antibiotics such as aminoglycoside class like gentamicin. So certain drugs can be nephrotoxic. Transfusion, pancreatitis, trauma. So they can all set off an acute kidney injury picture, which could of course lead to oliguria. Therefore, you need to review their fluid balance, examine for any volume depletion, so do a fluid balance examination, have a look at their hands, are they well perfused, are they warm, cap refill, their pulse, move on to the JVP, have a look at their eyes, are they sunken, especially the lower eyelids, have a look in their mouth, does it seem dry, parched, skin turgor as well, have a listen to their heart, does it sound fluid overloaded, obviously unlikely in those with hypovolemia, and feel for any edema if you're worrying about hypervolemia, and obviously as always take a set of obs, heart rate, blood pressure, all that good stuff. So urine retention could be due to medication. We know that opiates, especially morphine, can cause urine retention. So feel for an enlarged bladder suprapubically. Establish normal volemia using a central line, and you may well need to give them a fluid challenge, a bolus of fluid. And as it's pretty obvious from this slide, catheterizing them is a good way of monitoring their output general fluid balance. Checking the U's and E's is a very important bit of the blood panel, again helpful if you're worried about the kidneys. And finally, if there's an intrinsic renal failure, so what I mean by intrinsic is the pathology is related to the kidney itself as a cause of AKI, because we have pre-renal causes, intrinsic renal causes, and post-renal causes. So intrinsic renal causes, if you're worried about that, you want to be stopping first of all any drugs that could be affecting the kidney. So here I've just, for instance, NSAIDs, ACE inhibitors, but also aminoglycoside antibiotics like gentamicin, and obviously then refer for more help under the nephro team. Nausea and vomiting, very, very common post-op. So again, always think about the cause. Is it a mechanical obstruction? Some of the symptoms patients experience with a mechanical obstruction: colicky abdo pain, vomiting, distension, constipation. Okay. Ileus. So ileus, they wouldn't actually have any pain because the bowel is not moving. It's immobile. They may feel nauseous, but the key thing is they won't really have much pain. Likely to be distended though. And are there any emetic drugs? So those that sort of make the person feel sick. So opiates, anesthetics, really. Consider an abdo X-ray if you're worried about things like bowel obstruction. You can see, especially say for instance, if it's a small bowel obstruction, you may be able to see valvuli conniventes, which are basically lines going across the bowel. Whereas if it were to be a large bowel obstruction, you'd see the haustra, but these lines wouldn't go across the bowel because they don't. Whereas those in the small bowel do. NG tube, so if it's ileus, you may need to do a procedure, something called drip and suck, where you drip through some fluid via the NG tube into the bowel and then suck it out as a sort of medium to get the bowel going, really. Antiemetics may need to be prescribed, so cyclizine, ondansetron, domperidone. Another antiemetic is metoclopramide. You may have already known this, but it's not advised at all in those with suspected GI obstruction because it has prokinetic properties. So obviously, if you've got a GI obstruction and the bowel is undergoing peristalsis and it's trying to push against the obstruction, that's bad. So don't use metoclopramide until you're sure that there is definitely no GI obstruction. The others are safe, so you may as well stick to those. Also, metoclopramide, a problem often in young females, can often precipitate an oculogyrec crisis and can often be a problem in Parkinson's disease because metoclopramide is an antagonist at dopamine 2 receptors. Hyponatremia, often caused by quite enthusiastic and vigorous fluid input, so therefore often can lead to overdilution of the blood and can lead to low sodium. Bleeding, so we can classify bleeding into 3 bits really associated with surgery. So maybe primary, so this starts during the surgery. Reactive, often due to this is when the blood pressure rises and you start to bleed, and we may need to open up the wound again. And secondary hemorrhage often occurs a week to a fortnight after the operation and is often precipitated by infection. Right, so in terms of classifying post-op complications, we saw earlier we can classify it according to time scale, whether that be specifically for post-op pyrexia or just general post-op complications. When I went through the immediate, early and late complications, immediate within 1 day, early 1 to 7 days, and late 7 days plus. You may also want to classify post-op complications according to the underlying cause. So is it due to the anaesthetic, in which case it may present with respiratory depression? Is it due to the surgery? So is there a wound infection? Is there bleeding? Is there local anatomical damage as a result of the surgery? Or is there evidence of VTE? It may also be due to the specific procedure. And now we're going to be moving on to specific post-op complications. So things, for just one example here, saphenous nerve damage, because the long or the great saphenous vein is often used in a coronary artery bypass graft. So often when you're trying to resect that vein, you can often inadvertently damage the nerve. So that's just one. But again, as I said, PassMed has quite a good summary under the anaesthetics and perioperative care section of the surgery tab, going into sort of specific post-op complications with various surgeries, not just limited to, GI surgeries, as what we cover in Met 3A. Before I just move on to the specific post-op complications, I'll just quickly go through ileus. So ileus in this context basically means the bowel is not moving, and is actually a common complication post-surgery. It involves the bowel, and there's no peristalsis. It's not actually a proper mechanical obstruction. It's often known as a pseudo-obstruction, okay? And can often be associated with chest infections, MIs, strokes, AKIs, as well as sort of electrolyte abnormalities. And it can lead to the development of ileus. So therefore, monitor your use and ease, think about potassium, magnesium and phosphate. And we can replace those electrolytes through the IV route. Treatment is essentially wait it out, and if you're worried, the drip and suck method, which I mentioned, through the NG tube. Okay, so the last 3 or so slides now on specific post-op complications. So, laparotomy. Laparotomy, basically, you're cutting a massive incision through the abdomen, and can often present with problems in the elderly, the malnourished. So, things to consider here would be wound dehiscence, which is basically the wound starting to open up again post closing up. So first warning sign is pink serous discharge, and often the abdomen bursts open if it's very severe, and if it's left without, if you don't recognize those early signs, then there may well be evisceration of bowel content, so it comes out. So if you're on the ward and this does happen, what you can do is try and put the bowel back into the abdomen with a sterile dressing over the wound. Give them antibiotics, of course, to cover infection, and you probably need to return to theatre. Obviously, give them analgesia as well. Incisional hernia is very common at the site of incision, as the name suggests, and you can repair it with mesh insertion, often like normal inguinal hernias. Arterial surgeries, so obviously you should know that vascular is covered under the Met 3A module as well. So some specifics really, so bleeding, thrombosis, embolism, graft infection, MI, maybe MI due to like a thrombus dislodging, AV fistula formation. So complications of aortic surgery. So gut ischemia is one. So that could be as a result of poor blood supply to the gut. Renal failure, again poor blood supply to the kidneys. Respiratory distress, fistula forming between the aorta and the bowel, quite uncommon really, aorta-enteric fistula. Trauma to the ureters or the anterior spinal artery, which can result in paraplegia, and ischemic events, MIs, strokes. So some more specific post-op complications now. So biliary surgery. So often after exploring the common bile duct, we leave a small tube in to basically allow drainage of bile. It's often known as a T-tube. You do a cholangiogram a few days afterwards to make sure there's no stones left, and then afterwards the tube is pulled out. Any stones that remain can be got rid of using ERCP or further surgery, or you can often sort of drip through some dissolving agents to get rid of those stones. Some complications associated with biliary surgery include distal obstruction, formation of fistula, and may lead to the leaking of bile. The stricture may form in the common bile duct. You may have cholangitis. So cholangitis is inflammation of the biliary tree with Charcot's triad of right upper quadrant pain, fever, and jaundice. Bleeding into the biliary tree leading to hemobilia, which can present with biliary colic, which is sort of coming and going of right upper quadrant pain. Patient may also experience jaundice, hematemesis, pancreatitis, as well as a bile leak into the abdomen, which can irritate the visceral peritoneum and cause peritonitis. If jaundiced, for various causes, make sure to monitor coagulation, urine output because of the risk of hepatorenal syndrome, and consider antibiotics as part of your management. And final slide here now is just the final bit of post-op complications. If you're doing colonic surgery, certain things to be worried about include sepsis, ileus, fistula formation, anastomotic leak post suturing up the bowel together, adhesions forming particularly in open surgeries, hemorrhage, trauma to the ureters, and splenic trauma. Under small bowel surgery, a common complication is short gut syndrome, often when the sort of functional length of the bowel is less than 250 centimeters. Sort of symptoms patients experience include diarrhea, malabsorption, especially of lipids, can lead to metabolic abnormalities. So the fat-soluble vitamins, A, D, E, K, as well as B12 deficiency, may indeed have hyperoxaluria, so increased oxalate, which can form renal stones, or bile salt depletion, which can form gallstones. So management of this is actually very complex, but we're just basically trying to correct those electrolyte abnormalities and metabolic abnormalities. Finally, splenectomy. So can lead to gastric dilatation, often as a consequence of not using an NG tube. Low platelets and sepsis. We know the spleen is a secondary lymphatic organ, very heavily involved in immune system regulation, and sepsis is a major risk for those post-splenectomy, especially for bacteria including H. influenzae type B, Neisseria meningitidis, and strep pneumonia. So you try and prevent this using pre-op vaccination as well as prophylactic penicillin V. So that's all I have to say with pre and post-op complications. I know it was a bit detailed, but it is quite good to be aware of these things, not least because you will cover it again anyway in year 5. So I hope that's been useful. Thank you very much for listening, and good luck with all your exams.